we have the first slide, please? As some of you know, the iCAN-ACP project is a federation of pre-existing projects that were funded by the Canadian Frailty Network, and you can see those on your screen now. Next slide. The work of the Diversity Access Team cuts across and complements the three sectors of the project, which are primary care, long-term care, and hospital care. And as you can see on the slide, they build on these previous projects, and you can see the PIs there. Next slide. There are a number of common threads. We use the same definitions as the other three sectors. Sidori's definition of advanced care planning. We use the same conceptual framework. We use the same framework for outcomes. Next slide. But our target population is not only persons age 55 and over, and meeting the definitions of frailty as indicated in Rockwood's scale, but in particular, our focus is on marginalized and ethnic minority groups. And in this first round, the marginalized group we're focusing on, which builds on the experience of some of the members of the Diversity Access Team, it's LGBT individuals, and also we are focusing on Canada's two largest visible minorities, the Chinese and South Asians. And overall, the objective of our part of the project is to raise awareness and increase the use of ACP tools, and ideally of preparation and thinking about advanced care planning amongst these three groups. So the LGBT population, Chinese and South Asian seniors. Next slide, please. This shows our team. It's a national team. We have people from Nova Scotia to Vancouver, and some in California also, and Denny at McGill in Montreal. Next slide. Why focus on tools? Well, one of the reasons is that what we keep hearing is the need for education. And if you want to have consistency in how that education is presented, we want to have transparency, we need to have some tools to help us to do. In the same way that you can't measure or observe, you can't observe blood pressure, we can't observe values and preferences, but we can try to get those expressed. Because as this slide shows, 2/3 of older seriously ill patients have orders, medical orders that are inconsistent with what they really would like to have at end of life. Next slide. And so, as I said, our part crosses the three sectors of long-term care, primary care, and hospital care. And we began our work with the long-term care sector. It's modeled on the work of the Castellane and Sussman team, who have been working for some years in care facilities to promote the idea of a palliative approach to long-term care. And in this part of our study, we've done focus groups with staff, with residents, and with families, and to determine their basic understanding of advanced care planning. So in Vancouver, we have partners partnered with a multi-ethnic care facility that also is LGBT affirmative, and our second one in Vancouver is an exclusively Chinese care facility work is in progress in this sector, Halifax, in a facility that also is known to be LGBT affirmative. Next slide.
I'm here. My internet's back up and running, so Gloria, I could take over if you'd like.
Please do.
Okay, thank you. Sorry for the technological complications. This first slide represents the demographics of the focus group participants in the two facilities that Gloria just described. They were arranged in age, as you see, from upper 70s to low 80s. In the multi-ethnic facility, they were also largely Chinese, but exclusively so in the Chinese facility, with cultural backgrounds in the multi-ethnic that span a wide array and is much more exclusively described in the Chinese community. There were 8 in the multi-ethnic and 6 in the Chinese who participated in these focus groups. The next slide, please. This is a similar slide representing the demographic characteristics of the family members from these two facilities. 8 in the multi-ethnic and 5 in the exclusively Chinese. Age ranges comparable, but again, representing the sort of diversity of backgrounds in terms of nationality amongst those in the multi-ethnic and much more exclusively in the Chinese. These slides, as you've heard, I think will be available, and so this greater detail you could pursue at your leisure as well. That most of the family members were children, although some were spouses and related to the care recipient in a variety of ways. Next slide, please. This now represents the themes uncovered from the content analysis of the focus group. I've presented this slide in columns, since you see the residents and the families, and then in the rows represent the two care facilities as well as organized by theme. So if you were to read it across, one theme that was held in common by both the care homes was the extent of dynamics of discussions of advanced care planning and end of life. Even still, there were some interesting differences in how these themes were presented. If you compare residents, for example, across the two care facilities, what is fairly common is that there is a range of discussion and that the discussion often defaulted to post-death plans. What was unique is that amongst those participating in the discussion in the Chinese care home, is that there showed some real disdain for the discussion. In fact, a person got angry and threatened to leave the discussion because of the nature of it. If we look at the family in the two care homes, similarly, some challenges around the discussion, but amongst the participants in the multi-ethnic care home, a discussion of the regrets of not having discussed more, whereas amongst the participants in the more exclusively Chinese care home, it was more about the timing of such discussion, often having to do with completion of advanced care planning upon entry into the facility of the resident. A second theme had to do with staff and the advanced care planning and end of life. And the residents in both the facilities showed a kind of reliance on staff for any such discussion to begin. In the Chinese, they were cautious, some cautious discussion, but also mentioned open communication. Family members shared a similar kind of appraisal about the challenges and somewhat more positive discussions. The last column represents sort of themes more unique to each of the care homes. In the multi-ethnic care home for residents, for example, the residents spoke both of the pulls of families, that is to participate, to engage the direction of family, but also uniquely here, the absence of family. Similarly, uniquely, the multi-ethnic residents were more likely to speak of self-control and being self-aware, particularly around the timing of life's end and decisions to be made around that. In the Chinese care home, there was more of a letting it be, and in fact, a sense of age as the kind of default planner in all of this. It'll happen when it happens. Culture was raised by families in both of the care homes, more exclusively the conservative Chinese culture in the Chinese care facility, and the role of religion and the diversity of culture in the multi-ethnic care home. Next slide, please. If we move to the next slide, please. Thanks. This somewhat hard to see slide, but again, visible for you afterwards, is just a representation of the demographics of the staff who participated at these two care homes, the multi-ethnic and the Chinese. And in each of those, there were 3 levels of staff that participated, from support staff to care aides to registered staff. Primarily heterosexual participants, although in the multi-ethnic, there were some LGBT participants. The range of backgrounds more diverse in the multi-ethnic and more exclusively Chinese in the Chinese care, with a range of religious beliefs as well. The next slide starts to show the themes that were uncovered from the content analysis. This and the next slide, don't go there yet, please, represent the 2 broad similarities. That is to say, the common themes that have been identified in both by all the staff in both these groups, even as there are nuances in the presentation of these themes. So one common theme is that residents and had to do with the discussions about advanced care planning and end of life raised by residents. And even if it's not discussions, just comments about that and staff response. If we look at the support staff, for example, amongst the multi-ethnic and Chinese facilities, there was both limited discussion, of course. In the multi-ethnic, there was more of a likelihood that they would talk about referring this to the nurses. In both, there were some distracting kinds of discussions. Let's move on to another topic, they might say, or kind of placating discussions. Oh, you're going to be here forever, kind of thoughts. In the care home, amongst the care aides, for example, more consistently a reference to nurses. But the staff in the Chinese care home really felt kind of hobbled by such discussion. And as you'll see in subsequent themes, kind of pulled between what they perceive might be the critical eye of the families and the needs of the patient and wanting to be supportive of both. Registered staff were the ones who could engage more formally and listen and gauge the competence of the resident to follow through with such discussions, primarily amongst the Chinese facilities. With a second theme was knowledge and education, and in all cases there was a call for more information, not only on the part of the residents and their family members, but also the staff themselves. So limited knowledge and a need for education noted by the staff in both the facilities, support staff in both the facilities. A similar kind of discussion amongst the care aides and some direction for that amongst the registered staff. In particular, amongst multi-ethnic, a comment about the staff need to lead by example. The next slide, please. These are the final 2 broad themes across staff in the care home that staff raised and were encouraged to raise, really, issues of culture and end of life at all 3 of the care homes. At both of the care homes and all 3 of the staffs. And the culture kind of, the way in which culture was raised varied. In the multi-ethnic, amongst the support staff, there was broad discussion of culture, including their own personal backgrounds. Whereas amongst the support staff in the Chinese facility, it was a real clear awareness of, excuse me, Chinese culture and the sensitivities around end-of-life discussions. More introduction of LGBT cultures came in the multi-ethnic care home, which of course also was more LGBT inclusive. Generational issues discussed amongst the care aides in the Chinese facility, that is those who were born in Canada and caring for their parents who may have been born elsewhere. And amongst the registered staff, there's a deeper awareness of LGBT issues amongst the multi-ethnic registered staff that was less true amongst the Chinese staff. In fact, a little awareness, and in fact, laughing when the question of LGBT residents was raised to them. The role of families were discussed by all levels of staff in both communities, in both facilities, and mostly in the context of resident-family disagreements. That's probably fairly consistent across. What emerged is that as we moved across levels of staff to registered staff, there was a greater likelihood of calling for ethics committees or knowing how or discussing how best to intervene in such conflicts between residents and the families. So amongst the support staff, it was more of a sort of concern about how the staff aren't visited, and when they are, it's to be pride, to be for will kinds of things. Some of that as well amongst the care aides, and then more amongst care plans in the registered staff. Next slide, please. These are the unique themes in the final slide from this set of analyses that were emerged by staff at each of the two facilities. And so in the multi-ethnic facility, the support staff really spoke of the lessons they had learned from working with the residents. Amongst the Chinese staff and in the Chinese facility, spoke of the importance of relationships and personal communications, particularly for Chinese residents. In the care aides, they spoke of the importance of recognizing where these discussions take place, and said that in many cases, quote, we are their families for those who do not have families. And by that, they mean biological, traditional families. But yet they don't have access to the charts. And so they felt like they had a deeper level of care without the same sort of information. In the Chinese facilities, you see, they spoke of wanting to provide comfort and how comfort in the absence of pain were important at end of life. And finally, amongst the multi-ethnic registered staff, they spoke again of their personal experiences with advanced care planning and often referencing their own personal culture. And amongst the Chinese and registered staff, spoke of the benefits of advanced care planning and documenting resident wishes and a way to do so better of when such documents could be used and how they could be created. It's the end of my section. I pass it on now with the next slide.
Because we found that there were very few LGBT residents or families of residents who were LGBT in our two facilities in BC, as well as in the one in Nova Scotia, and we felt it was important to hear about the lived experience of people. We have done a sub-study where we had a focus group with people who had a loved one, either currently or in the past, in a long-term care facility. Next slide, please. this shows the sample, the age range from 54 to 82, and that all of those were themselves members of the LGBT community. You see on the slide that 2 had a common law partner, 1 had friends in in long-term care, 1 was considering long-term care for herself, and the other was a person who had been the director of care in an LGBT affirmative home in the past. Next slide. While they expressed many of the same kinds of concerns as other long-term care groups, such as issues and concerns about the first bed policy in BC, and the fact that even where their wishes were known, they had to go where a bed was available. But the themes that came through loud and clear that were unique was the one about aging alone, reflecting the demographic reality, because we know that many LGBT older adults are alone. They do not have the same kind of family support structure as other persons growing old. And so they really underscored the idea of not having anyone that they knew and could trust to give the responsibility of a POA, or being their representative, or being their executor, or even of being able to talk to about advanced care planning. And reflecting what Brian noted in the focus groups with staff, this is the other side of it, where in fact we had the families, our respondents, saying that sometimes it's very helpful if there are LGBT staff that they can relate to. There's a shared identification, and they become almost surrogate family. Next slide, please. We've begun our work in the second phase of the long-term care sector, and as you heard from Brian, a number of the staff had said that they really wanted education. And so what we're doing in phase 2 in the long-term care sector is actually providing education sessions for staff and for families. We're introducing some tools which they then can take away, and then we follow up to talk with them after a period of time to find out if they've used the tools and if they've found them helpful. So in the long-term sector, the 2 tools that we're concentrating on are the 2 versions of the Your Conversation Starter Kit. The orange one is more targeted to residents themselves, who have the cognitive capacity to fill out a workbook, and the purple one is targeted to people who have loved ones, residents who are demented. Next slide. We have done two education sessions already at the multi-ethnic care home. We had a total of 25 staff turn out. We have a second one that is scheduled for the Chinese care home in next week, where we expect to have an attendance of about 20. The purpose here is to give staff the background so that they can assist residents and families in identifying or in having their goals of care conversation and other aspects of advanced care planning. The research design is a pre-post design, and staff fill out 3 questionnaires, one on perceptions of barriers to ACP, another one getting at their understanding, and the third one, the extent to which they see advanced care planning as within their scope of practice, and their feelings of self-efficacy in being able to engage and to assist in those kinds of conversations. Next slide. The education sessions were conducted by Jane Webley, who's the regional leader for palliative care within Vancouver Coastal Health. Next slide, please. The next slide shows the topics that she covered. And she is the same person that did the education sessions for the team in Ontario, but in our particular case, she also added a segment that deals with cultural needs. And so in addition to her talking about these topics, the staff also had an opportunity to do a bit of role play. Next slide. In the primary care sector, we've conducted 3 sub-studies, all with the same methodology, where we do a focus group, we do a telephone follow-up at 4 to 6 weeks. The objectives here are to determine baseline understanding of advanced care planning, introduce tools, and get feedback from our participants on the relevance of those tools for their particular group. And so you're now going to hear about the 3 studies. The first done in Montreal, led by Denis Dubé, who is a social work PhD student at McGill. So could we have the next slide, please? And Denis, it's your turn.
Thank you, Gloria. So if we're looking at this focus group in particular, the subgroup number 1, so we were interested by gay men aging with HIV. It's an interesting and marginalized group. We talked about gay men in prevention. We talked about gay men in the HIV context that were dying from AIDS, and the aging gay men population with HIV is quite a new phenomenon. There is actually a growing number of older gay men with HIV for 2 reasons. There are more men that have adequate medication today and that are aging well with HIV, or as well as you can with a chronic disease. And there are more older gay men contracting HIV, so that's reality, statistics reality. And we know little about their needs regarding advanced care planning. We didn't explore this yet. It has not, there's no real studies on that yet. Their particularity is dealing with a lot of intersectional stigma, so a mix of ageism, HIV stigma, homophobia, ableism, all interacting together, making the stigma really impacting their daily living. There's an accelerated aging phenomenon that's also associated with HIV, and they do face a lot of isolation, rejection, and blame. Let's not forget that for men that are 50 plus today, that are aging, gay men that are aging with HIV, a lot of them, homosexuality was illegal when they were young. They could be prisoned for homosexuality. Then they got through the HIV crisis. They lost a lot of people, a lot of rejection, a lot of blame related to being gay, and then with HIV, they have faced, and they still do today. And within the context of the study, we thought that all these could be challenges or barriers for engaging in advanced care planning. Can I get the next slide, please? So if we look a little at the sample to get a flavor, so we gathered 7 gay men aging with HIV, ages from 55 to 73, living with HIV for long times, 17 to 29 years, and they all had two plus comorbidities, ranging from cardiac and blood pressure, respiratory diseases, cancer, cholesterol problems. 6 of them were single, only 1 in a relationship, and annual income was pretty low for most of them, and only 1 participant had an income superior to $50,000 a year. Only 1 participant was owning his own house, and all other were tenants. Next slide. So as we described, the methodology was to conduct a focus group. So basically the focus group was to ask them what their thoughts were about end-of-life care, what their worries were, and so we discussed that. And the second part of the focus group was to present the guide and to ask them what they thought about that tour. So if I go through some of the themes that came out of the group, so the first theme is living in the moment. So most participants expressed the need to focus on their present life, meaning that their precarious context was taking so much energy out of their daily doings that they were kind of not able to envision the future or future care that they would need. It seemed to be very difficult for them. If I go through like the two quotes that are there, I was saying that for me, it's more important to worry about my health now, to live fully now. What will happen to me after, I don't even think about it. But I think about all that is happening to me right now, and that worries me. So, you know, that was quite common in the comments participants were making. The worries were really about present issues. The second quote, so since I don't work anymore, I don't know if I will be able to pay for everything, all my expenses. So I will have to cut the cable or my phone, something like that. That way I can wait until I get a more suitable apartment for my income. As I described in the sample, most of these participants were quite in a precarious situation. So this was some kind of worry that came out. Can I get the next slide? The second theme was isolation. As it came out a lot with the ACP focus groups and other work that we've been doing in the team, isolation was really predominant in the discussions with this focus group. They basically looked connected and said they were connected to community and other, but they were not really. And as they discussed together about this, it was quite clear that they felt alone and isolated in their journey with HIV and aging. Even if they were using some of the community services, in a lot of instances, one participant would name an organization, they live in the same city, and they wouldn't know about it. Some quotes. So first, I think about the main problem. For people who are aging, it's isolation. What I'm saying is that I am myself included in this. It's isolation. So it was clear, and it was talked about not covertly, but really overtly, that they felt isolated. They didn't use other words. They really used, I feel isolated. I see people sometimes, but I really feel isolated. The second quote, even more for LGBT people, because they are disconnected from their families, couples, or children. I have seen couples with children, but a lot do not have children. So we end up even more isolated. And when you add HIV, it's a factor that exacerbates even more. So if I go to the third findings, the next slide, please. So disclosure, I had not anticipated that this would take so much place in the focus group, and it did. HIV disclosure was a particularly sensitive aspect of how gay men aging with HIV can feel isolated. It seemed to be not only with their experience today, but within their life story, how disclosure has always been something that they had to worry about in healthcare with their family, and some of them have not been out in some parts of their life for the longest time. So to have a very personal discussion as advanced care planning becomes challenging. If I read the quote, so for me, it's a little difficult because my children don't know that I have it, AIDS. And it's the thing that I have wanted to keep for myself. So my sister, my mother, and all that know, they knew, but what I can't push myself to do is to tell them that I have AIDS. So for that participant, their children don't know that they're aging with HIV. If we go to the next slide. So one particular thing with our focus group is that the follow-up, the 6 weeks follow-up we did by phone and email, mostly by phone with these participants, most of them reported not to have used the guide, it seemed very difficult for them to re-engage with the conversation starter kit that I had left with them. And for me, it's consistent with what came out from the focus group. It's difficult, obstacles are there, and I think that they're really real for them. And it's not something that is easily accessible for them to jump into this conversation about end-of-life care. If we look at implication and discussion, implications of this study, so it can be a coping strategy that focusing on the day-to-day that comes with the stigma and rejection that they felt and experienced as aging with HIV. Focusing on future is complex. It requires support, which in most cases, they reported not to have so much support. Isolation makes it difficult to identify someone with whom to reflect and communicate for further care needs. As much as they were connected with some community organizations, when we were talking about particular people that they could discuss end-of-life care with, apart from that one group member that had family close by, it was difficult for them to identify. There was no one. Assessing for and addressing isolation is a necessary step to support gay men aging with HIV's readiness to engage in ACP. I don't see a way for them to engage in this kind of planning if they're this much isolated and have no one to talk to close to them. And finally, those with a strong circle of care may be better equipped to use current ACP tools. Again, reporting about this more connected participant that had family close by and that seemed more informed about future care. He had a will, things were planned, and it was a real shift between the rest of the participants and him. And the big difference, I think, was his living condition and proximity with his family. That would be all for me.
Robert, are you there?
Yes, absolutely.
Okay.
So the study that I'm working on is called Exploring and Advancing Advanced Care Planning Among LGBTQI2S Older Adults Living in Non-Metropolitan Communities in BC. Research on LGBTQ populations is typically urban-centric. So this study has two primary objectives: to explore the level of ACP knowledge and readiness in LGBTQI2S individuals residing in non-metropolitan regions of BC, and then also to provide a planning tool, a workbook aimed at activating advanced care planning discussions. In the province of BC, without advanced care planning agreements in place, in the event of an emergency or illness that renders the individual incapable of decision-making, a temporary substitute decision maker is chosen from a prioritized list set out by BC law. Given the varying support network structure in LGBTQ communities, who, for example, often rely on families of choice, and these include close friends in comparison to more traditional family networks. The preparation of an advanced care plan is vital to ensure one's temporary substitute decision maker may carry out the decision-making process. And next slide, please. The planning tool I've been providing to focus group participants, and they have it to take home, is My Wishes, My Care. It's a test copy designed by the BC Palliative Care Organization. The research designed for this project includes a collection of participant characteristics. This usually takes the first 15 minutes of our 2-hour session, and the remaining time is a focus group session of about 90 to 100 minutes. The participants are given the guide to take home, and at 6 weeks, I gave them a choice of either an email or telephone follow-up. Everybody's chosen the email follow-up so far, and this is carried out to ask participants if they have read the guide and to outline what steps, if any, they have taken in terms of advanced care planning preparation. So next slide, please. So between September 27th and October 24th of this year, I completed 6 focus groups with 32 participants. The smallest group was 2 people, the largest was 8. I thought this was an interesting note, attesting to the importance of this topic and perhaps the lack of availability of being able to access this information. In 3 locations, I had people travel quite a long ways to come to the focus groups. In Nanaimo, a gay man drove 140 kilometers round trip to participate. In Port Alberni, another gay man drove 218 kilometers round trip to participate. And in Kelowna, a trans participant drove from Vernon, which is 51 kilometers each way to participate. For the study, the age mean is 67.3 years and the range was 55 to 84 years of age. The mean number of chronic conditions was 2.7 and the range was 1.1 to 6. And 8 of 32 used some form of assisted device. This sort of attests to that there is some frailty in the group that I have been looking at. 12 of the participants were female, 11 lesbian, 1 identified as fluid. There was 1 male to female trans woman, she identified as lesbian, and the remaining participants were 19 men, 18 of those identified as gay and 1 identified as sexually fluid. 14 of the participants had children, and the number of children were from 1 to 6. The relationship status, 10 were legally married, 11 had a common law marriage, 10 were single. 4 of the singles were never partnered. I thought that was an interesting fact. And then 1 listed that they have a boyfriend. In terms of ethnicity, 3 participants identified as other, 1 a combination of white and other, and 28 of the 32 identified as white. For the follow-ups, in the research design, it was stated a follow-up telephone call or email will be made within 6 to 8 weeks of the date of the focus groups. All participants chose the email, as I mentioned. At this moment in time, I've completed 6 6-week follow-ups with 2 Kelowna participants, 3 Nanaimo participants, and 1 Salt Spring participant. Since the focus group, all 6 of those that I followed up with have read My Wish is My Care, and 1 participant noted that he had read it several times. In response to one of the follow-up questions, which is, if you had not prepared an advanced care plan prior to attending the focus group, have you now prepared or taken any steps to prepare an advanced care plan since your attendance? Examples of steps taken may include conversations about advanced care planning, visits to website for additional information, attendance at advanced care planning workshops, etc. And I asked them to please describe their experiences. In the people I've done the follow-ups with, 5 of 6 participants have taken some action. The other person felt that her affairs were in order. As such, from the perspective of an intervention, the project at this early point in data collection appears to be a success. Next slide, please. The focus groups are still in the process of being transcribed. One general note from the focus groups was that people tended to fixate on the medical components of care. A 67-year-old gay man clearly stated, dialysis no, feeding tube no, pacemaker no, ventilator no. So he certainly was clear on what he did not want. Then there was less talk about non-medical issues, but the conversation was powerful, with a 60-year-old lesbian participant stating, I do not want a nightgown, pajamas, top and bottom. It's kind of important because as a child, being sexually abused, the nightgown, it's easy access. And I think this is a really important statement to show the level that we need to talk about just your wishes as opposed to the medical care issues. Because, she would have been terrified if she was in a hospital setting and had a gown put on her. And so that is where the project sits at the moment in time. We expect the interviews to be all transcribed and all of the follow-up data received by December 19th. After that date, we will begin coding the data. And in the meantime, next up in the discussion is advanced care planning among ethnic Chinese older adults. Thanks.
Next slide, please. The third of the sub-studies in the primary care sector was exploring advanced care planning amongst ethnic Chinese. And what got us into this particular study was we realized that although some of the well-known advanced care planning tools have been translated into other languages, there's no evidence that we could find that they had been tested for cultural appropriateness. And it just seemed like we needed to do that before we paid to have anything translated. So our objectives for this study were to examine the knowledge and readiness for ACP amongst ethnic Chinese adults, to explore ways of increasing ACP in the Chinese community, and to determine the extent to which the tool that Robert was testing and that has been prepared by the BC Center for Palliative Care is culturally appropriate for Chinese older adults. So this is also with the same methodology as Robert's study. So these are, in effect, intervention studies where we explore the background, give them the tool, and then follow back to see what they have to say. Next slide, please. This shows the sample. There were seniors that belonged to a senior center in Richmond, BC, which is a geographic area with a high concentration of Chinese older people. As you can see, 6 of them were from Hong Kong, 2 from China, 1 from Vietnam. And that's important to note because those countries were all countries that have had some exposure to European culture. And so we will be doing a second focus group with Chinese seniors, but with people from mainland China. So this group is mainly from Hong Kong area. Next slide, please. What comes out very clearly in the discussions was, first of all, as with the care facilities, the exclusively Chinese care facilities, they talked a lot about superstition and the reticence of many traditional older adults in the Chinese community to talk about death. And the quote is an example of somebody who said, you know, I'm reluctant to donate any of my body parts because when I'm reincarnated, I will be missing those parts. A second key theme was the idea that maybe education by fear was a way to increase advanced care planning. This surprised us when we heard it, but what they suggested was, instead of telling people about the advantages of advanced care planning, focus on the disadvantages. If you don't have a will, your kids will fight with each other. A third key theme that came out with this group was the point that the Chinese are not a homogeneous group. And so even in people from Hong Kong, those who came to Canada before or after 1997 are different populations. Similarly, although there are other people who are of Chinese extraction, if they came from Taiwan, if they came from Indonesia, from other places, they have different sets of values. And that was an important lesson for us. You know, we talk about the diversity within the seniors community. We need to think about the diversity within the diverse cultures. Next slide, please. In terms of the primary care sector, we have another set of studies that are planned and that haven't commenced yet, where we will be interviewing primary care physicians who have a substantial proportion of their practice either with LGBT or with Chinese or with South Asian older adults, to determine their experience and readiness to engage in ACP conversations with these groups, and if they have done them, what they have found to be barriers and facilitators to such conversations. Next slide. Also, not yet conducted but planned, are some studies in the hospital sector where we will interview hospital staff to determine their experience and their readiness to engage in ACP conversations with our 3 groups of interest. We plan to engage an LGBT expert panel to look at the tools that are available and being used in the hospital sector, in particular the Serious Illness Conversation Guide and the best and worst case scenario tools, We will also interview LGBT and Chinese and South Asian patients and families on what they think to be the cultural appropriateness of these tools. Next slide. And these next couple of slides, for those of you who aren't familiar with the serious illness care program, to familiarize with you. So next slide. This just shows you some of the questions that are asked when you use that particular guide. Next slide. So I think that gives you an overview of what the diversity access team is doing. We have had an interesting time of it. We are a diverse group ourselves, and we have had the opportunity to do some innovative, I think, studies, and we look forward to coming back next year to tell you about the ones that we have will be starting in the new year. So for further information, please feel free to contact me or to contact Shimai, who is our project coordinator. Thank you, and now I think we have time for maybe a few minutes of questions.
I don't see any questions that have been posed yet to the web platform. A comment from John Yu thanking us, and I appreciate that, and thank you for participating, and to the others who have joined us as well. Perhaps having no further questions, Gloria, maybe we could just conclude kind of right on time.